All right, nurses and night shifters, welcome back to Discussions with Dr. G. I'm Dr. G, your guide through the wild world of muscle relaxants and that mysterious monster known as spasticity. This episode, we're breaking down muscle strains and spasticity, what they are, why they knock your patients flat, and how you can sound impressively smart explaining them to your friends or, your clients. So let's start with muscle strains. We've all overdone it at some point. Actually, embarrassing story. Last summer, my niece decided Auntie G should play tag at the park, right? I'm thinking, how hard could this be? Well, turns out, very hard. 5 minutes in, pop. I pull my hamstring. Didn't even get tagged. So technically, I lost to a first grader. Anyway, that was a classic grade 2. I think definitely more than mild soreness, but nothing torn all the way through. Here's what's happening under the hood with strains. You've got 3 grades. Grade 1, just some extra stretching, maybe a few micro tears, swelling, bit of weakness, but nobody's calling 911. Grade 2 is a legit partial tear. You'll see pretty significant loss of function, bruising, swelling, the works. That's what happened to me at the park. Grade 3, that's the big one. Muscle fibers are actually ruptured end to end. I mean, you usually need imaging to confirm, but clinically, that leg is just done for a while. The healing process follows a pretty logical path. First, destruction. That's where the cells break down, inflammation kicks off. Then there's repair, where the muscle fibers rebuild. And finally is the remodeling stage, where your body tries to patch things up as strong as, or let's face it, sometimes just as scarred as before. If you push too hard too soon, you end up with chronic pain, scar tissue, maybe even compartment syndrome. Not worth it for a playground race, trust me. Now, spasticity. That's a bit of a different beast. We see this all the time in neuro patients. Think spinal cord injury, stroke, multiple sclerosis, even traumatic brain injury. Spasticity happens when the excitatory and inhibitory balance in the central nervous system goes haywire. So instead of nice, controlled muscle contractions, you get hyperactive reflexes, muscle stiffness, abnormal posturing, and all sorts of lovely clonus and contractures that absolutely grind down a person's daily life. If you've ever seen someone struggle to pick up a coffee cup because their fingers just won't unclench, yeah, that's spasticity in action. It messes with function, but also with dignity and independence. The big hitters causing spasticity are things like stroke, spinal cord injuries, traumatic brain injuries, multiple sclerosis, cerebral palsy, dystonias pop up too. I mean, that's a whole greatest hits album of neuro conditions. And what does this get you? Complications, of course. Contractures, skeletal deformities, mobility that goes from awkward to please send help, pain, and oh yeah, a nice hit to the quality of life. I'll tell you, I'll never forget my first clinical rotation with a patient living with MS. She was this unbelievably positive woman, even as her legs did their best impression of cement pillars. It really hit me, though. Spasticity isn't just about muscle tone. It's about independence, dignity, even the basic stuff like getting dressed or making it to the bathroom before you use the bathroom without a bathroom, if you know what I mean. Completely changed my view on what matters most for patients. Getting a handle on this stuff made it so much easier for me to rehab after my own injury. Once you know what's happening, you're way less likely to push your luck and way more likely to heal smart. All right, so let's crack open the medicine cabinet. Safety, of course, because these drugs do pack a punch. Let's start with centrally acting muscle relaxants like cyclobenzaprine, baclofen, tizanidine, even benzos like diazepam. So, cyclobenzaprine is kind of the OG for acute muscle injuries. It works by depressing the central nervous system. So, yep, you guessed it, drowsiness and funky dizziness are the name of the game here. That's why Grandma's not going to Pilates after taking her Flexeril. Baclofen is big for spasticity, especially in MS. It mimics GABA, so it's all about calming those spinal cord signals. Problem is, you stop it abruptly, especially if it's through a pump. That's when the circus comes to town. Hallucinations, seizures, rebound spasticity. Always taper baclofen, guys. Seriously, tiny doses can make a huge difference. Just remember, you gotta taper it slowly or you're gonna open up a whole new can of withdrawal worms. Tizanidine is an alpha-2 adrenergic agonist, which is a really long-winded way of saying it makes the brain chill out, therefore lowering muscle tone. But you gotta watch out for hypotension, hepatotoxicity, and probably, predictably, sedation. And then there's the benzos. These are sort of your double agent. They're great for spasticity, calming that CNS with GABA, but they also bring on sedation, dependence, dizziness, confusion, GI upset. Oh, and let's not forget the dark side, the risk of respiratory depression, especially when you add opioids, which please just don't. That's always going to be a no. Dependence is a real risk. Use these short term, taper them, and if things really go sideways, you're really going to have to watch it with old folks. They don't bounce back from just a little sleepy like you might think. Flumazenil is your antidote, but you're going to want to use it cautiously. Now, before we get started with NMBs or neuromuscular blockers, I want to explain very quickly 2 eye conditions that are going to be discussed in this next part. It's strabismus and blepharospasm. I want you to think of your eyes like a pair of binoculars that must move together to focus clearly. In strabismus, the muscles controlling the eye movement do not work together, and so your eyes point in different directions. This can cause double vision or poor depth perception because the brain receives 2 different images and may turn off one eye to avoid any confusion. Now I want you to imagine your eyelids acting like a camera shutter that keeps snapping shut without you pressing the button. That is blepharospasm. Your brain is sending abnormal signals to the muscles around the eyes, causing them to contract uncontrollably. Okay? Now I will start the discussion on NMBs, neuromuscular blockers. Sorry about that, guys. For pre-op nerves, we're talking succinylcholine, also known as SUX, rocuronium, or ROC, vecuronium, or VEC, and the ever-popular Botox. All right, indications for these agents. Big surprise. They're not just for anesthesia and intubation, although we do use them there. We use NMBs and Botox for spasticity, dystonias, cerebral palsy, even stuff like, ready, strabismus and blepharospasm. But here's where it gets interesting. There are major contraindications. So succinylcholine is what we call a depolarizing agent. So it basically binds to acetylcholine receptors, causes this big synchronized muscle freak out, rapid depolarization happens, and then everything goes limp. This is off the table for folks with any kind of neuro injury, major burns, tissue trauma, hyperkalemia, or Duchenne's muscular dystrophy. Also, you need to know that succinylcholine can trigger malignant hyperthermia. Imagine your muscles cooking from the inside out. Yes, it really happens. I remember once in the OR, we had this patient develop a temp of like 105. just suddenly out of the blue. It was wild. People started running in with buckets of ice, turning the room into a meat freezer. It was crazy, y'all. Malignant hyperthermia is why we keep dantrolene stocked and at the ready in the OR, by the way. So rocuronium. Rocuronium, on the other hand, is non-depolarizing. Think of it like the bouncer at the club, just blocking the receptor so no depolarization happens at all. Now, whether it's Sux, Rock, or Vec, think full-on paralysis. No muscle tone, not even a twitch, which is why it's super useful for intubation and surgery. But don't even think about giving these drugs without ventilatory support at the ready. You have to have your patient ventilated with this because there's no muscle tone. They cannot breathe on their own, okay? So if you see succinylcholine and malignant hyperthermia in a question, ring the internal medicine bells. Moving on. Then there's our glamorous injectable friend, onabotulinum toxin A, better known as Botox. That's right. It keeps acetylcholine from being released at the neuromuscular junction, which means the only thing paralyzed is a very specific muscle group. Thank you very much. Now, not to be confused with, hey doc, can you do crow's feet while you're at it? Because let me tell you, injecting Botox for wrinkles does not improve someone's gait after a spinal cord injury. I tried making that joke to my med-surg class and nobody laughed. Honestly, poof, tough crowd. Anyway, with Botox, if there's an infection at the injection site or you've got hypersensitivity, yep, that's going to be a hard pass. Botox is milder, but it can still surprise you. Dysphagia, dyspnea, spread of the toxin, even anaphylaxis. Oh, and you thought we were done? No, we're not. Let's talk peripherally acting muscle relaxants like dantrolene. This one's all about reducing calcium release in the muscle cells. It's great for spasticity from spinal cord injuries, multiple sclerosis, cerebral palsy, stroke, and life-savingly for malignant hyperthermia, as previously discussed. The big warning, hepatotoxicity. If your patient turns yellow or their urine goes from being straw-colored to tea-colored, ask for an LFT pronto. Dantrolene and sick livers do not mix. Oh, and women over 35 who are also on estrogen, that's a maybe don't. So precautionary, if you will. You got to watch for weakness, dizziness, diarrhea, or sometimes constipation, because who doesn't want both? Adverse effects include, you guessed it, hepatotoxicity and respiratory muscle weakness. Actually, I had a patient with MS, let's call her Sarah. She was really struggling with spasticity despite the usual stuff. We tried baclofen, we tried therapy, but what really turned things around was dantrolene. Her mobility improved, fewer spasms. Suddenly she was able to get up and go out for walks again. Of course, we kept an eagle eye on her liver enzymes, but for her, it was a total game changer. So bottom line, know your drug classes, watch the dosing, and pay attention to not just the effect, but also those sneaky adverse effects that are lurking in the background. Okay, so we've got the pharmacology smorgasbord, but how do you, the nurse or student nurse, keep all these priorities straight? First up, assess, assess, assess. It is the first step in the nursing process for a reason. Be a detective. If you're giving cyclobenzaprine or honestly any central relaxant, fall risk is real. Make sure you're monitoring CNS depression, asking about how they're actually feeling, and not just trusting the MAR. If you're starting dantrolene or tizanidine, monitor those liver enzymes, like you're looking for buried treasure, guys. If your patient's on a neuromuscular blocker, Don't leave them alone with the call bell. They need ventilatory support and close respiratory monitoring. Basically, the full ICU treatment. Don't get cocky just because you pushed succinylcholine 100 times. Things can change fast. And with benzos, be honest, if you're mixing those with opioids, you could be sending your client into respiratory depression. Nobody wants that paperwork. Trust me. Client teaching is everything here. First, no alcohol, no sedatives. Not even that just one glass of wine. No, these meds magnify drowsiness like nobody's business. Stress the importance of reporting yellow skin, persistent weakness, or trouble breathing right away. No toughing it out. If you're administering something like baclofen, go over tapering schedules and tell them not to stop it suddenly or things can get ugly. Picture this. A patient comes up post-orthopedic surgery. Add a cyclobenzaprine to their meds. Besides pain control, your main priorities are fall prevention and monitoring for sedation. Do your safety rounds. Remind them the bed alarm is on. Make sure everything they need is close by. Phone, water, food, pen, paper. All right, you get the idea. Good teaching moment, actually. Patients think just because this is just for muscle pain that it's no big deal. But hey, one sleepy stumble is all it takes. All right, guys, key takeaways. Botulinum toxin is for focused spasticity, not the whole body, and those effects last about 3 months, okay? Dantroline's for spasticity and malignant hyperthermia, but you gotta watch the liver. Tizanidine and baclofen work centrally, but need slow tapers and organ monitoring. Benzos are your last resort because they are high risk with lots of rules. If you're feeling overwhelmed, trust me, you are not alone. I still double check every time I reach for these drugs. So to wrap up, it all comes down to critical thinking and communication. Monitor, teach, adapt to what you see. Don't just follow the order set because the computer said so. Now, go pet a cat, take a walk, and let all this pharmacology percolate. Catch you next episode.